possibilities. And so finally, I got to colorectal cancer. Do you want me to keep going? I mean, I'm happy to. I can talk about this, almost as much as how the Yankees are doing against the Cleveland Indians tonight. But I don't want to make people feel obligated to stay. You want me to keep going and talk a little bit about, particularly about the issue of predicting Erbitux response and where that stands. Let's go on a little bit. Well, we all know that the FDA approval was for IHC staining with the PharmDx test from DACO again. We knew that 85% of all colorectal cancers were positive. So immediately we knew that since the response rate to the antibody was not 85% of patients, that the test was not very discriminatory against who would respond and who wouldn't. But nonetheless, that's how ImClone and developed the antibody. That's how it was in the trials, so the FDA was compelled to do it in the approval. And they approved again on the same day, the IHC test and the drug. And it was pretty, very cumbersome. We had to find the blocks from these primary tumors from years ago in these patients who now had relapsed with liver metastases to do the IHC test, so we could then make the patient eligible to get the drug, even though we weren't going to in any way predict whether they would respond or not. And that went on for a number of years until finally data that many people, myself included, predicted came out that the RAS pathway, when constitutively activated by a classic mutation in the hotspots for RAS, which are on the first exon, usually codons 12 or 13, and some 61, but mostly 12 and 13, would bypass the EGFR inhibition that an antibody or a small molecule probably could achieve, and continue to stimulate downstream the proliferation and progression of the disease. So clinical data was accumulated, and retrospective at first, and then even some prospective, that if a colorectal cancer had a KRAS point mutation in mostly codon 12 or 13, the patient had a zero chance of benefiting from the anti-cancer effects of cetuximab. Although the FDA has not changed to date the label of cetuximab or the subsequent approval of tocilizumab from Amgen, which is also an anti-EGFR antibody, of course, they nonetheless have seen third-party payers require documentation of RAS wild type, lack of mutation, before their willingness to pay for cetuximab therapy for colorectal cancer. What percent of colorectal cancers drop off when RAS mutation is done? About 50%. But that's not the end of the story. Work is now continued on the RAS wild type group, because not all of them respond as well. And mutation testing first in the BRAF, usually a special hotspot called the V600E, I've shown that these BRAF mutated patients don't respond, and they add about another 12%. And then there's been studies that P53 mutations and loss of PTEN expression. So the number of patients eligible for cetuximab therapy in colorectal cancer is decreasing as we speak. And you can see the position for the third-party payers. These are expensive therapies, and if there are tests that can reliably predict a patient's resistance to them, it's not going to take the FDA's decision to change practice. The third-party payers will lead the way, I think, in this case. So here we see this is the EGFR IHC positive, and this is so common in colorectal cancer, and it really doesn't tell us very much, and it certainly doesn't predict response to cetuximab. Here's the EGFR gene amplification. We can do FISH and count the copy number. This hasn't had as big a role in colorectal because the gene copy number and the antibody response haven't been so linked. This becomes important in the lung cancer, whether we decide is EGFR mutation testing or EGFR amplification testing the best way to predict the sensitivity of a lung cancer to the tyrosine kinase inhibitor erlotinib, or in Japan, erlotinib, or gefitinib, Iressa, or Tarceva. Tarceva not on the market here currently. So we don't see the copy number. It seems that a low copy number in one study, meaning not amplified, is a prediction of resistance to cetuximab in colorectal, and a high copy number, amplification, is predictive of sensitivity, but it's not being done anywhere that I'm aware of, at least for colorectal. EGFR copy number, and here's some data for that. For mutation testing, since this is not the small molecule, it doesn't appear that mutations in the EGFR tyrosine kinase domain has any impact on whether the antibody therapeutic will benefit the colorectal cancer, or for that matter, the head and neck, or even the lung cancer. And erlotinib does not have an indication in colorectal cancer as of this moment. KRAS we've already talked about, and ASCO has given this provisional opinion. All patients with metastatic colorectal carcinoma who are candidates for anti-EGFR antibody therapy should have their tumor tested for KRAS mutations in a CLIA-accredited laboratory. If KRAS mutation in codon 12 or 13, I would add 61, but they didn't, 12 or 13 is detected, then patients with metastatic colorectal carcinoma should not receive anti-EGFR antibody as part of their treatment. So despite the third-party payers feeling this way, despite the FDA not acting, ASCO has issued a provisional opinion saying don't use Erbitux in RAS-mutated colorectal cancer. And of course, there are a lot of technical issues. You know, the standardization and validation of RAS point mutation assay is lacking. There's no FDA clearance for any RAS mutation tests that I'm aware of. Some assays have a sensitivity that's not as high as others and require enrichment by microdissection of tissues. Others don't require that and thus are somewhat sensitive to false positive results if the sensitivity is too high. Some tests have a very high DNA extraction efficiency, and you get very few cases from one procedure that insufficient DNA was extracted to do the mutation, and other tests rarely, if ever, fail to get a result. The question about what about frame shift and missense mutations? Should we just be looking for point mutations? That's a question that's not resolved. And should we add codon 61 and not just do 12 or 13? So we do need some standardization here. Yes, we know RAS mutation is important, but let's have a test that can be reliably reproduced from lab to lab and not have a whole series of tests that perform not equally well so that all patients get a good RAS result that can be relied on. And we've talked about this. And this is just more RAS data we don't have time to go through. Here's a whole list of the many, many different types of RAS mutation testing. You think it's like one test. It isn't. There's many ways to do it, very many ways to do it. And we're still not, how we say, the consensus on what's the best technique. BRAF, 0 to 13% in the literature. I think I read 12 was fairly reliable, but it may be lower than that. Again, V600E sequencing is where the focus is. Inverse relationship with RAS. You don't see BRAF mutations in RAS-mutated tumors or vice versa. It's either one or the other, and it picks up about another 8 to 10% of colorectal cancers that probably are resistant to cetuximab as well. AKT1 is rarely identified, 1 to 3% additional non-mutated RAS that may be cetuximab resistant. We mentioned P53. Again, doesn't have a standardized result. I don't recommend doing immunohistochemistry for this. Picks up about another 5% or so of the RAS wild types that still are P53. Most P53 mutations actually occur in RAS mutated, but some occur in RAS wild type, and they apparently appear to impart a cetuximab resistance as well. P10 expression loss in about 40%, but it's mostly in mutated. But there are a few cases of P10 expression loss in RAS wild type, and those don't respond to cetuximab as well. So I think over time there's going to be a test algorithm, and the number of eligible patients is going to drop significantly from the beginning. For 5FU, there was some interest 10 years ago and 7 years ago that we could do RT-PCR-based testing for thymidylate synthase and the dihydropyrimidine dehydrogenase and use that data to predict responsiveness to a 5FU-based regimen in metastatic colorectal cancer.